I'd like to first congratulate the term officer for this extraordinary meeting, and thank you for the invitation. For the next 20 minutes or so, I will speak about the contingent screening we are advocating for cell-free DNA contingent screening at the Fetal Medicine Foundation. So it is contingent because the subgroup of patients that will receive cell-free DNA testing will be selected on the basis of the combined test. I don't think I have to explain here what the combined test is. We all know that roughly, combining maternal age, nuchal translucency, and free beta ECG and papillae, we are able to detect about 90% of trisomy 21 cases, 95% of trisomies 18 and 13 at a false positive rate of 5%. We have been discussing and even yesterday, the importance of continuous monitoring and quality control, and to know how the screening program is actually working. And that's exactly what we did. We published last year. And this is a prospective validation study of the FMF algorithm carried out in more than 100,000 patients. And at a false positive rate of 5%, 5.3%, which corresponds to the cutoff of 1 in 100, we detected 92% of trisomy 21 cases and about 95% of trisomies 18, 13, monosomy X, triploidy, and about half of the other chromosomal abnormalities that were diagnosed in that group. And I say about because unless we perform analysis of all the babies, cord blood, or any kind of karyotype after birth, we won't ever know the true denominator of that fraction. So this was meant to be a screening for Downs, but additionally, and as a beneficial side effect of that, we were detecting already all those things. We also spoke about malformations, fetal defects, that inevitably, if we are doing first trimester scan, we will be detecting. And we know that many of them are strongly related to chromosomal abnormalities. That's the case of increased nuchal translucency, exomphalos, I don't know if this point, exomphalos, megacystis, or holoprosencephaly. If we look at that group, that represents about 1% of the population. Professor Kaigan said that yesterday. But that group, in that cohort of 100,000 patients, already contain almost 60% of the chromosomal aneuploidies. And you have the breakdown there. 50% of the trisomy 21 cases, 72% of the 18s, now almost 90% of the trisomies 13. So first, when we perform the first trimester combined test, we can identify this subgroup of about 1% that should receive an invasive test directly, and well, probably they are not candidates for cell-free DNA testing. But it's not only the scan, it's also the risk itself. So if we look at different cutoffs, we focus at the cutoff of 1 in 100 for defining the very, very high risk. And if we just took the group of patients that were in between 1 in 2 and 1 in 10 risk, we found 70% of the trisomy 21 cases, about 90 of the trisomies 18, and just by adding fetal heart rate, which takes a second, up to 85% of the trisomy 13 cases. So perhaps this 1 in 10 group of patients, which also represents 1% of the population and includes many of the patients with fetal defects, could also be a candidate for direct invasive testing instead of cell-free DNA test. Now, we recently updated the meta-analysis of performance of cell-free DNA testing. There's no much else. There's no much to say. I mean, the numbers are impressive. Detection rates are getting higher, and more importantly, false positive rates are getting lower. Of course, it has all sorts of bias. To me, the most important one is the effect of the failure rate. Because none of the studies, and this is how we did the meta-analysis, include failures within the calculations. So basically, we remove failures, and we calculate the performance, the detection rate, and the false positive rate based on that. And we know, and we will see later, that that group without a conclusive result is enriched with aneuploidies. But anyway, not many more things to be said. All right. So I always bring this slide, and I always update the last line here, because even if we think that the false positive rate is very low, when we say, well, 0.04, that's nothing. Well, if we use the test in a low-risk population, our routine population of perhaps, or for example, 100,000 pregnancies, and we do cell-free DNA tests for all of them, if the number of cases with the normal prevalence of Downs is 200, yes, fine, we will be detecting, we could say, all of them, it doesn't matter, but inevitably, even if it's 0.04%, we will also be calling somehow 40 cases abnormal, trisomic, when they are actually euploid. So it is always important, after a positive result from the cell-free DNA testing, that we do an invasive procedure. So the points I'd like to discuss today is, first, which conditions should we include in the panel when we request our cell-free DNA test? How do we interpret the results? Why is it important, the fetal fraction? What we were saying before, test failure. What happened with twins? And finally, and that's the end of the presentation, models for implementation. Right, so in terms of conditions to include, I think there's no discussion. This is the test for trisomy 21. I think we all feel comfortable with trisomies 18 and 13, and they are, we could say, standard now, and they perform pretty well too. But what happened with sex chromosome aneuploidies? I'm not geneticist, but the sex chromosome aneuploidies that worry me, and I think all of us, are the lethal type of Turners. Because, well, those Turners that we detect by increased nuchal translucency, or what others call cystic hygromas, but for the rest, not much, because if any, they have mild effect, mild intellectual disability, nothing really worrying. Additionally, 50% of them are mosaics, and many actually confined to the placenta. There is also high incidence of maternal mosaicism that will be worsening the results from the cell-free DNA test. The performance is not that clear because the quality of the studies is very poor. In the meta-analysis, we gave fantastic numbers, but they were very biased because most of the studies assessed the karyotype by the phenotype. And that's valid for trisomy 21 or for trisomy 18, but not for sex chromosome aneuploidies. So it doesn't work that well. And finally, if we get a positive result, when do we do the invasive procedure? Because it's obvious that we cannot do a CVS. We need to wait until 16 weeks and then to do an amniocentesis. Fine, what happened with aneuploidies? So we could argue that, especially in young women, they are far more prevalent than trisomy 21. So that could be an argument, and some of them can be very, very nasty. We think of the George, and maybe they could benefit of an early treatment. But there are several limitations for this. To start with, the technology. Cell-free DNA testing still is not able to detect deletions or duplications of less than 3 megabases. So by definition, even if it was perfect and it detected all of them, it would be a maximum of 85% of the cases of 22q syndrome that would be detected. 70% of Angelman, 85% of 1p deletion, and so on. So apart from that, when we look at the papers that have been published, the detection rate varies a lot. So anywhere between 60 to 100%, the samples are half artificial, no good follow-up rate, etc. So the main problem of this is that we are adding false positive rate. We were starting by 0.04, and now we are adding an extra 1%. For a positive predictive value that is very low, only 5%. And, well, for all these reasons, it is probably the future, and hopefully it will be, but not yet. And that's the summary I wanted to tell you. Yes, trisomy 21, yes, 18 and 13, and not for sex chromosome or triploidy, and not yet for microdeletions. So we get the report, and they come very simple, really. They say more than 99% chance, less than 1 in 10,000, no aneuploidy or aneuploidy detected. So we just give that to the patient, and that's the same for everybody. It doesn't matter what patient we have in front of us. No, it doesn't. It does matter. So how do we do that? We look at the patient, we take her prior risk, and we adjust by the positive and the negative likelihood ratios, as we do for everything, at least at the Fetal Medicine Foundation. So what is the prior risk? The prior risk, if we have nothing else, is maternal age. If we have the combined test, it's the results from the combined test. And then if the test comes positive, we multiply by these factors. If the test is negative, we divide by for those factors. For example, we have a patient, a very young one, with a risk of 1 in 100,000. That patient decides that she wants to have cell-free DNA testing because she wants it. It's the best test. She wants it. And it comes positive. And it says, your risk is more than 99%, or aneuploidy detected. And she says, well, then I want a termination. And you say, well, yeah, more than 99%, go ahead. Well, no. If we adjust this likelihood ratio, positive likelihood ratio, into that number, you will get 2.4%. So there is a 97.6% chance that the baby is normal. So we need to do a CVS. And on the other side, if we get all women, or for whichever reason, her risk is 1 in 2, and the test comes negative, and I think that's a mistake there. Anyway, so it doesn't really matter. Yes, we can reassure her, but her risk, even if the test is negative, but her risk is not less than 1 in 10,000. All right, next point. Why is important the fetal fractions? Well, because of the nature of the test. If we are looking at the condition that is in the baby but not in the mother, the more DNA that there is in the mother's blood that belongs to the baby, the more accurate the test will be. And that's represented here. So the blue dots are trisomy 21 cases, and the representation is fetal fraction against Z-score. And the red dots are trisomy 21 cases, and the blue dots are euploid cases. So the higher the fetal fraction, the more we move to the right into this graph, you can see that the Z-scores, so the difference between normal and abnormals that arises from the informatics in the test is bigger, and they don't make mistakes. It's almost a diagnostic test. But the lower the fetal fraction is, the greater is the overlap between normals and abnormals, and that's where the problems come. And this is a modeling study, and basically it shows how the detection rate increases when the fetal fraction increases, and so the same do the likelihood ratios. Traditionally, all the companies set up a cutoff of 4% in order not to give a result because they didn't feel confident. Now, because the sequencing is deeper and the technique is improving, they are giving us results with lower fetal fractions. But no matter, it will always be important. It doesn't matter that the technique is better. There will always be a minimum, because without fetal fraction, we cannot do the test, just simply like that. Right, there is a recommendation from the American College of Obstetricians and Gynecologists that says that whenever we get a failed result or a non-conclusive result, we should offer the patient an invasive procedure, because there is an increased risk of aneuploidies. So, and we know also, we heard from Professor Kagan yesterday, that between 1% to 3% of the patients don't get a result. So we have a fantastic test that has a 0.04% false positive rate, but now we are adding 1 to 3% of extra invasive procedures because the test failed. So is it that simple? We look at more than 10,000 cases of cell-free DNA tests performed between 11 to 13 weeks, and we look at the fetal fraction into the different conditions. There was no difference between euploids and trisomy 21 cases. Well, that makes sense because they have a normal placenta, but the fetal fraction was significantly lower in cases of trisomies 18 and 13. And that's also logic because they have a smaller placenta, lower papae. So was that related to the failure rate? It was. So there was no difference, again, between normal and trisomy 21 cases in terms of failure rate, but the failure rate was very much increased in cases of trisomies 18 and 13. Therefore, when we get a failed result, there is not increased risk of trisomy 21. There is an increased risk of having trisomy 18 or 13, but those are the conditions we normally detect by the scan, by looking at fetal defects, and those are also the cases that from the combined test, they get very, very high risk. Again, what happened in twins? Well, for monochorionic twins, if we make it simple, they are the same, so genetically they are the same, and the test should work the same, if not better, because there are two. But anyway, what happens with dichorionic twins? Because they are different, and they have two different placentas. And it can be that the placenta of the normal baby is bigger than the placenta of the smaller baby. So that normal one is contributing the most into the maternal circulation. So it can be that the normality of this baby masks the abnormality of this one. And the test cannot differentiate between one twin and the other. So they say normal because they get a fetal fraction of 4, and perhaps all of it, or maybe 3% of that is these babies, and just 1% is this one. So what have the companies done? Well, one of them measured the fetal fraction of both twins and takes into account the higher of the two. Some other companies, they increase the threshold, and they say instead of giving a result with a 4% failure rate, fetal fraction, we will give it if it is at least 6%. And some companies, they don't do it. And we have heard many times that the failure rate is increased in twins. Well, obviously, if we need more fetal fractions, there will be more tests that will fail. But is that related to twinning, only to twinning, or is there something else? So we look at the same cohort of more than 10,000 singletons, and we compare that with 438 tests performed in twins. And yes, we found that if you look at here, the blue line is singletons, spontaneous conception, and the red line is twins. So this group here is spontaneous conception, and we found that the factor affecting the most to the failure rate was actually conception by IVF. And what happens is that twins are more frequently conceived by IVF than singletons. So yes, twinning increases. So if we compare spontaneous both groups, yes, twinning increases the failure rate. You can see it here. But actually, the most important factor was the conception. And that was the reason in our cohort. Is the technique validated for twins? And we could discuss largely. But when we look at the studies published with complete data and this and that, we found very, very, very few cases. 24% of trisomy 21 from stored samples, only 25 from prospective studies. So it seems that it works well, but we don't have enough data yet. Now, what is the contingent model we are always advocating for? So we believe that, and especially in Europe, when we routinely perform combined tests, I believe almost in every country, not all, but most of us. So we do combined screening to all women at 11 to 13 weeks, and afterwards we classify them into a very high risk, a low risk, and intermediate risk. High risk will be that group of patients that will be offered directly an invasive procedure. And for example, if we take the 1 in 10 I was discussing before, we will find all those cases. And then we need to define the low risk group. And that is probably where money affects the most. So the cheaper the test is, the lower can be this risk so that we offer the test to more patients. So you have here an example of different cutoffs and the detection rates and false positive rates that we would be able to achieve. And finally, we are always speaking about non-invasive testing, because we are comparing with the invasive testing that traditionally, according to different societies, you have them here, the risk of miscarriage after an invasive procedure is 1%. And that's what many of us still tell the patients. But is that true? Well, I present this study here from Professor Akolekar that he performed in 2011. He essentially took a cohort of patients screened in the first trimester, and he compared those that had a CVS. Well, first, he took the cohort that did not have a CVS, and he looked at the factors that were predictors for miscarriage. And logically, he found that maternal age, nuchal translucency, the reverse ductus venosus, and low PAP were affecting. So any of those were giving an increased risk of miscarrying without doing anything. Then he looked at the cohort of 2,400 CVSs, and he applied that model into this cohort. So the expected number of cases based on this regression was 45, and the actual number of cases that he found were 44. So not significant. The recent study from the Dainius group, and Tabor's group, the same group that published in the Lancet back in the 80s, the famous 1%, has recently published this fantastic study, very, very well done, and they also found no significant differences. So to conclude, in terms of which conditions to screen for, we know that 21, 18, and 13. We must modify the prior risk with the positive and the negative likelihood ratios when we receive the report from the lab. The fetal fraction is important, yes, but it depends on the company, because some companies, they don't measure and they don't report it, and therefore those companies will have a lower failure rate, and some companies report it, and therefore the failure rate they have is higher. So we think it's important. The test failure, does not increase the risk for trisomy 21. So if the test fails, don't say, go for an invasive procedure, take the scan machine, have a look at the baby, and if everything is normal, repeat the test. There is a 50 to 60% chance that you get a result, and if not, go back to the prior risk, go back to the reason why you perform the cell-free DNA test, and decide if that patient needs an invasive procedure really. There is a lack of data for twins to conclude that it works, and we believe that the best way of implementing the test is to offer it to the intermediate risk group of patients. And don't forget that when we are counseling a woman, we cannot tell her the risk of miscarriage is 1% anymore, because it's closer to 1 in 1,000. And that was everything I wanted to tell you. Thank you.